Good morning, good afternoon, and good evening, everyone. Welcome to World Breastfeeding Week 2025. Today's webinar, Building Healthcare Systems That Truly Support Breastfeeding, New Tools for Sustainable Change, is brought to you by WHO, UNICEF, and in partnership with the Global Breastfeeding Collective. I am Fatmata Fatima Sise, nutrition specialist infant feeding with the Child Nutrition and Development Program Group with UNICEF headquarters in New York. And I'm delighted to be your moderator today. Thank you all for joining us today on this important topic. But before we start, I would like to remind everyone of the housekeeping and Zoom etiquette. So for today's webinar, we offer interpretation in Arabic, English, French, Spanish, and Russian. And to switch languages, click on Interpretation. If at any point during today's webinar you are unable to hear the speakers, please make sure you've connected your audio by selecting the headphones icon. Closed captioning in English has also been enabled for this meeting. And to view the live English subtitles in your screen, click on the CC icon and select the Show Subtitle. Please note that this webinar is being recorded, and submit your questions for the panelists in the Q&A box and direct your question to a particular panelist. And panelists may be able to reply to your question via text in the Q&A box, or will answer your question during the live Q&A discussion of the portion of the webinar. So just to set a little bit of the context here today, I am sure you will all agree that embedding skilled breastfeeding counseling support within healthcare systems is essential to improving maternal and child outcomes and building stronger and healthier communities. As we may all know, the Baby Friendly Hospital Initiative, for instance, has made significant strides in integrating lactation care and support within the healthcare system. However, after over 30 years of implementation, we've learned that in order for breastfeeding support and care to be sustainable, we must ensure that BFHI is integrated as a standard of care in health systems for sustainability and scale up, as detailed out in the UNICEF WHO implementation guidance of 2018. Today, we have an exciting lineup of speakers who will take us through 3 new tools and updated materials. And also, we will have 4 panelists who will share their country and regional experiences with engaging healthcare systems and beyond in order to strengthen the delivery of breastfeeding support. Basically, our goal here today is to familiarize you with these new resources and encourage countries to strengthen their healthcare systems to truly support breastfeeding. So at this point, I'm just going to go through briefly what we have today as an agenda to help us achieve some of these goals that we have highlighted here today. So I'm going to share our agenda for today. Next slide, please. We will start with opening remarks, followed by a very powerful video featuring voices of mothers, because their experiences are the heart of why we are here today and what we continue to do. And then next, we will explore 3 new tools to support breastfeeding in healthcare systems. 1, we will talk about the Baby Friendly Hospital Initiative new monitoring manual. Then we will talk about the competency verification toolkit that's upcoming and the updated model chapter on infant and young child feeding for medical textbooks and allied health professionals. After that, we will have a panel discussion where experts from the Gambia, East Asia and the Pacific, the United Kingdom and Lebanon will share their country-level experiences of integrating breastfeeding support into the healthcare systems. Then we will open the floor for your questions and answers and close with a call to action. So to kick us off, it's my pleasure to introduce to you today Dr. Luz Regel, who will be welcoming us to World Breastfeeding Week for 2025. Dr. Luz is the director of the Department of Nutrition and Food Safety at WHO. She is responsible for the work of the department with member states and partners to prioritize, plan, implement, monitor, and evaluate multi-sectoral efforts to ensure universal access to effective nutrition actions, safe food, healthy diets through the strengthening of health systems, and building forward better food systems while recognizing their independence in the health of humans, animals, and the wider environment. Dr. Luz is an epidemiologist with 20 years of experience in public, private, and non-profit and international intergovernmental sectors. She has authored more than 150 peer-reviewed policy publications and has served in multiple international advisory bodies in public health. Colleagues and everyone, I hand it over to Dr. Regel for her opening remarks. Over to you.
Thank you so much, and I have the pleasure to welcome you as well on behalf of the World Organization to this webinar. It is really a pleasure to be here, and I first will start by congratulating the community that is supporting breastfeeding. Over the last years, we have seen that there is remarkable progress in the rates of exclusive breastfeeding. And this is one of the few targets that we have almost achieved by 2025. Today, around half of the children are exclusively breastfed during the first 6 months of life. That is a remarkable achievement of a community that is coming together. Such a community is here, the Collective for Breastfeeding, UNICEF, and of course, WHO. And this is not a minor achievement. Does that mean that all the work is done? No, I think that we all know that we are here for more, because we know that breastfeeding is the first vaccine. It saves lives. And as such, in many places in the world, is the difference between living and dying in a child. Today, the theme is reminding us how important it is that women receive all the systemic support. Sometimes, and we often hear it, it feels like a lonely battle. Women are convinced, but they just don't have the support systems to breastfeed in the exclusively. So today, we are reminded that we need works that support breastfeeding, but not only as a requirement, as a policy requirement, that actually embrace breastfeeding as something that makes the job better of women, of course, but of many. The community needs to be around it. We also are reminded that hospitals have the duty to ensure that breastfeeding is established, that healthcare providers are trained properly to ensure that women receive the appropriate counseling. We are also reminded that the entire community has a role to play in ensuring the safe and of course, effective breastfeeding. I will stop here because I know that you have a very, very packed webinar, but I just want to remind everyone that recently the World Health Assembly approved an extension of the global target for breastfeeding. Now the task is that in the next 5 years, and I believe that is possible, we can increase by 10 percentage points the rate of exclusive breastfeeding to 60%. The number of lives that will be saved by increasing those numbers is remarkable. The number of benefits in health outcomes from preventing undernutrition and long-term outcomes such as reducing the risk of obesity in children or in the mothers is remarkable. So breastfeeding is a no-brainer, but it won't happen unless we all come together and continue supporting this in a very holistic and address the issues at a systemic way. So with that, I hand back the microphone to you, Fatima, and I wish everyone a very fruitful webinar.
Thank you so much, Dr. D. Regil, for those inspiring opening remarks and for setting the stage so beautifully for our discussion today. Your words remind us why this work is so critical for mothers and children worldwide. Next, let's hear the voices of mothers. This is why we are all here, to ensure mothers have the support they need to reach their infant feeding goals. What better way to kick off our webinar presentations today than to hear from the mothers themselves?
J'ai réussi à allaiter grâce au avec toute l'équipe qui était formée et qui répondait à mes demandes, à mes sollicitations jour et nuit avec beaucoup de bienveillance.
Mình đã cho con trai ti được 39 tháng rồi, bởi vì mình đã cho con ti được ngay từ những ngày đầu tiên sau khi sinh, cho nên hành trình cho con ti mẹ thực sự là rất đơn giản. Mình mong rằng là tất cả các nhân viên y tế đều có kiến thức đúng về sữa mẹ để có thể hỗ trợ những người mẹ có thể cho con ti đúng ngay từ những ngày đầu.
Mothers around the world want to breastfeed. They need support to make that happen.
When I had some difficulties, they said, you'll do that, don't worry, you will do that.
كنت أعاني من قلة إدرار الحليب، ومع أخصائية الرضاعة أعطتني بعض الإرشادات والتوجيهات من ضمنها خطوات فعالة لزيادة إدرار الحليب.
The pediatric doctor came to assure me about my preterm baby's 26 weeks, and she told me she just need 1 ml from the colostrum. Since that time, my baby completed her breastfeeding journey for 2 years.
Breastfeeding support in healthcare systems is essential. When it's missing, mothers and babies pay the price.
The help I wish I had from healthcare providers is advice on breastfeeding, physically showing me how to do it.
32 ngành dược sĩ, đa số những dược sĩ cùng nghề với mình chưa được cập nhật những kiến thức đúng về sữa mẹ.
Unfortunately, I had a lot of misinformation that confused me.
분만실에서 간호사 선생님이 제게 모유 수유를 하면 아가 체중이 줄 텐데 괜찮나요? 라고 물으시길래 제가 무척 혼란스러웠던 기억이 있습니다.
Los pediatras me dieron una información errada y me dijeron que debía darle de lactar a mi bebé cada 3 horas.
아기 태어나고 완전 모유 수유 희망한다고 했었는데도 굳이 3시간 아니면 새벽에는 콜 없이 분유로 수유했던 게.
However, with the right training, healthcare workers can change the story for mothers, babies, and families.
I had lovely nurses that sat with me, helped me to breastfeed, encouraged me.
ولدت ولادة قيصرية، أعطوني إياها ورضعتها رضاعة طبيعية. بالنسبة لأنها هي بريتيرم، النيرس علمتني أختصر الحليب.
Cảm ơn nhân viên y tế được hướng dẫn tự bú đầu tiên và được hướng dẫn về ý nghĩa của sữa mẹ.
ባለሙያዎች አሁን አገልግሎት የማገኘው ከ10 እስከ 12 ጊዜ በቀን መጥባት አለበት ልጁ ሌሊትን ጨምሮ ማለት ነው።
ናዞ asibiti awo ma'aikatan lafiya suka bani shawara. Yaro na ya tashi da kuzarin jikin shi kuma ba cututtuka.
ogeessonni fayyaa waa'ee haadha sirriitti barumsa adda addaa naa kennaniiru.
ولله الحمد من قبل ومن بعد تمكنت من إرضاع. أرشدتني إلى أهمية الرضاعة الطبيعية وكيفية مص الطفل للحلمة.
When staff have the training to help, mothers feel fully supported, even when challenges arise. What ensures every parent gets that kind of care? Evidence-based lactation training for every healthcare worker who supports mothers and babies.
Hoàn toàn trực tiếp nhờ sự hỗ trợ của đội ngũ tư vấn viên sữa mẹ, mình đã vô cùng biết ơn tất cả mọi người.
Agradezco mucho todo eso y valoro mucho.
It just made all the difference with all 3 of my babies.
កូនដោយទឹកដោះផងដែរខ្ញុំសង្ឃឹមថាបងប្អូនស្ត្រីគ្រប់រូបនឹងទទួលសេវាកម្មនៅមន្ទីរពេទ្យ
da shawarar da ma'aikatan lafiya suka bani saka da
muna godewa
Allah ya ci gaba da muna godiya sosai akan shawarwarin da suke bamu. Allah ya saka da alheri.
والحمد لله زادت نسبة إدرار الحليب لدي. شاكرة قسم الرضاعة الطبيعية على مساعدتها وفي الاستمرار على
Gracias por todos los retos que pudimos superar juntas.
Nhưng chúng tôi không thể làm điều này một mình.
Want to improve breastfeeding outcomes and community health? Invest in lactation training for all maternity staff within your healthcare system. It's the most powerful step you can take.
Cảm ơn nhân viên y tế.
Tất cả mọi người.
សូមអរគុណ.
Wow. Wonderful. Thanks to the mothers who share their experiences with us today. As we can see, their voices make it crystal clear that when healthcare workers are equipped with the right knowledge and skills, mothers truly thrive. When they are not, mothers and babies suffer. This is exactly why we are here today, to explore the tools that can make this vital training a reality in healthcare systems worldwide. So I'm just gonna go over quickly to the tools that we have today and introduce the tools. We have an exciting lineup of speakers, as you can see here, who will take us through the 3 new tools that have been updated. The speakers will discuss monitoring, routine breastfeeding support and care, assessing health worker competency, and a model chapter for pre-service training and for medical and allied health professionals. So let me take time to introduce our speakers for today. A biography for each speaker will be posted in the chat. And colleagues, just to restate, we are all familiar with the baby-friendly hospital initiative and the various tools on the 10 steps to breastfeeding. However, to ensure sustainable healthcare system changes, tools are needed at every level to improve adherence to the 10 steps at facility and at national level. So first, I will present the Baby-Friendly Hospital Initiative Monitoring Manual, which is so important for effective monitoring and delivering quality breastfeeding support. And this manual will serve as an invaluable resource for facilities and countries working to build their lactation support. Then Dr. Lawrence Grummer-Strong will be enlightening us about the competency verification toolkit, ensuring competency for providers of breastfeeding care. It's my pleasure to introduce Dr. Larry Grummer-Strong, who is the unit head of the Food and Nutrition Actions in Health Systems at WHO. He coordinates the work of WHO on infant and young child nutrition, prevention and treatment of acute malnutrition, prevention of micronutrient deficiencies. Until 2014, he served as the chief of the U.S. Centers for Disease Prevention and Control. He earned a PhD from the Princeton University. He worked at the CDC for over 23 years in the areas of reproductive health and nutrition. He is an epidemiologist who has published over 180 scientific publications. He leads the Baby-Friendly Hospital Initiative, the Code on Marketing of Breast Milk Substitutes, and the Global Breastfeeding Collective at the WHO. As we will hear from Larry, it's really critical to confirm competencies of those who provide lactation care. But there has been a critical gap in preparing them before they even begin their careers, ensuring that they have foundational breastfeeding skills, knowledge, and support from day one. Larry, over to you, please.
All right, good morning all. Thank you for the time today. So I want to talk about how we assure competencies of our providers. Next slide, please. So to begin with, just to set some background, the Global Breastfeeding Collective, led by UNICEF and WHO, has set out a number of areas where we really need to do a better job in supporting mothers to breastfeed. Number 5 in our set of 7 calls to action really focuses on access to skilled breastfeeding counseling as part of comprehensive breastfeeding policies and programs in health facilities. This call to action really focuses in on having skilled breastfeeding counseling. And so we really want to focus today on how do we ensure that our healthcare providers are in fact skilled, that they're not just giving standard messages, they're not just reading from a pamphlet, they're not giving advice that might be inconsistent from one to another, but really have the skills that they need. Next slide, please. By way of background, the WHO put out guidelines several years ago on breastfeeding counseling that in some ways revamped, kind of came up with a new paradigm of how we should be thinking about breastfeeding counseling. Prior to this, we were really thinking about kind of if a woman needs help, she can come and find someone for that help. And what this new guideline really focused on was that there, in fact, need to be 6 critical contact points. We need to be touching mothers in the pregnancy period, in the hospital period, as well as continuing to follow up with her during the 2 years after birth to provide the kind of guidance that she needs, the preparation, the support to really make sure that she is able to breastfeed and gets the support throughout that time period. Next slide, please. And in fact, what this guidance really pulled out was that there needs to be a more comprehensive approach to this. It needs to be a continuum of care across antenatal care, perinatal care, and postpartum care. And we need to make sure then that healthcare workers have the competencies to actually provide the kind of support that is particular to that point in time. So during pregnancy, we really need to make sure that they are getting the kind of support that is necessary in preparing themselves for breastfeeding. Whereas later on, it's a matter of once they've established breastfeeding, how to actually continue that and deal with the challenges that they might have in their environment. This means we need to have different skills at different touch points, different knowledge, but we also need to have a systematic approach that our healthcare facilities are really providing the support that women need throughout this, not just waiting for problems to occur. Next slide, please. To build this, we really need to be moving toward a competency assessment base to really ensure that healthcare providers have these skills that they need. For a long time, we have talked about competency-based training. And while that is critically important to have the training be competency-based, it's not enough because just because we're providing the kind of information, the knowledge that might be there, even trying to work with staff, if we don't see that they have in fact absorbed the information and are able to apply it, then we're just really talking about providing this training. We're not actually ensuring that we have the support that's necessary. Recognizing this, in 2018, with the new guidance on the Baby Friendly Hospital Initiative, WHO and UNICEF put out new guidance for healthcare facilities. That step 2 is not just about providing a training. There was a 20-hour training course, and people said, oh, we just need to make sure that all the staff have sat through this training. But just because you sit in a classroom doesn't mean that you actually have the sufficient knowledge, competency, and skills to support breastfeeding. And so healthcare facilities have the responsibility of verifying that their staff really are equipped to provide the appropriate care. In that guidance, we also talked about their national responsibility, that countries have the responsibility to make sure that healthcare professionals going into facilities have the ability to actually provide that support. So we need to make sure that they are trained in the implementation of the 10 steps, but not just knowledge training, but that we're actually checking that they in fact have absorbed those skills and are ready to step into service, providing the support that mothers need. Next slide, please. So in that context, WHO worked with a number of outside partners to develop a competency verification toolkit to really unpack what are these core competencies that healthcare staff need in delivering the Baby Friendly Hospital Initiative, working through those 10 steps within the facilities, and how do we actually then assess that? And we had 16 core competencies, defined performance indicators on how we would measure it, and provided a number of tools for assessing those performance indicators. There was a general toolkit, a general tool of describing how this should all work together, an examiner's resource of the tools that they need to work through, and then specific sets of multiple choice questions to really get at the knowledge, case studies to work through specific circumstances, certain situations, and make sure that the healthcare providers taking courses, and working in facilities are able to work through real situations, and then observation tools to actually see them on the job, that they actually are providing the care that they ought to be providing. Next slide, please. So this has been out and was actually launched 5 years ago at a World Breastfeeding Week webinar in 2020. We are now in the process of finalizing a competency verification toolkit for breastfeeding more broadly. So we're expanding beyond that focus just on the perinatal care in the 10 steps for hospitals and birthing clinics, and expanding that to make sure we're including antenatal care and postnatal care as well. So it's an expanded one. It's building upon the experience that we've had over the last 5 years with applying the toolkit, some of the difficulties and challenges with that, and making sure that we're trying to provide a better tool. One of the things we've done is we've simplified from the 16 competencies down to 11 competencies to make it more understandable and manageable of what we're really trying to focus on as the key competency. But then have to expand the number of performance indicators because of the broader time frame that we're looking at here, different kinds of skills that are needed in antenatal and postnatal care. Also have greatly expanded the number of case studies and observation tools within this, because we recognize that there was probably too much focus in the original tool on the knowledge base. We really need to have those tools to work through the case studies and observe our healthcare providers in action to see that they actually are in fact demonstrating the competencies that are needed. So it's an expanded package, expanding both in terms of the time frame that it covers, as well as the expansion of tools available for this competency assessment. We were hoping that we would actually have it online by today, but we're still working through some final details before we can post it online, but hope to have it available for you within the next couple of weeks. Do want to thank the Baby Friendly Hospital Initiative Network, who worked with a very multinational expert group to develop many of these tools. We worked very closely with them throughout this process, and so huge thanks to them for it. But we really have built upon the experience that they've had within Baby Friendly to make sure we're building from that. Next slide, please. Just want to close with talking about how this is best to be used. The uses of the toolkit can be at various time points. As you're hiring new staff into your healthcare facility to verify that the staff are actually able to provide the services that are the responsibility at your care. They might be used for a specific unit within a health facility to check periodically that the staff on an ongoing basis are still providing the appropriate care that they ought to have. Those who are involved in continuing education, providing CME credits or other CERPs, et cetera, the kinds of continuing education that healthcare providers need. How do we actually design the courses that are addressing those skills that are perhaps deficient and they don't have an adequate set of skill sets? As we're working in facilities on quality improvement, these can be used to define what kinds of changes are needed to improve the quality of our care. And individuals can use the toolkit to assess themselves and say, how do I actually plan my own continuing education to fill the gaps for the aspects of my care that I'm not as good as I'd like to be? So this is how we hope that it can be used. Hope to have it out there for you within the next few weeks or so. Next slide, please. I just want to thank you very much for your attention this morning.
Thank you, Larry, for that excellent presentation on competency verification. I am now honored to present to you the Baby Friendly Hospital Initiative Monitoring Manual. So just a little bit of a background. Earlier this year, UNICEF and WHO released the BFHI Monitoring Manual. And basically, this manual complements the BFHI implementation guidance that was released in 2018, which emphasizes the need for effective data management systems to ensure continuous quality improvement and adherence to the 10 steps. Next slide, please. So the manual really provides guidance on monitoring at 3 levels. And monitoring, as we all know, is needed within healthcare facilities themselves, externally, to provide quality assurance checks, and at the national level for program planning and evaluation. And the most important thing here is that in all cases, monitoring should lead to learning and corrective action as appropriate as possible. So basically here, the 3 levels of monitoring included in this manual are: 1, internal monitoring, which is basically facility tracking for improvement, and then ensuring that this is reported. This is conducted at the facility care level to identify areas of improvement, track progress to date, and gather data and information for independent external monitoring entities. Then we also have the external monitoring part, which is done by independent evaluators, and then basically working towards corrective planning. And it's really about evaluating whether maternity care facilities are adhering to the 10 steps for successful breastfeeding, and then planning corrective actions. Then the national part is really used to track the overall application of the evidence-based practices to protect, promote, and support breastfeeding recommended practices used for program planning and evaluation, especially at national level. Next slide, please. So what is this? What is included in the manual? So the manual really covers indicators for each level of monitoring, those 3 levels that I highlighted earlier on. It also included recommended data collection options and tools, including the strengths and limitations of some of these options we have proposed in the manual. It also provides guidance on data processing and analysis, as well as sample questionnaires. As some of you may know, as described in the 2018 implementation guidance, indicators for facility-based monitoring, for example, should focus on the clinical practices, which are basically steps 3 to 10, and then the periodic evaluation of the management procedures covered in step 1 and 2 are important, but generally do not require routine data collection. And the audience described here for using this manual are wide, ranging from those that are dealing with internal monitoring, external, as well as national monitoring. Next slide, please. So, colleagues, I'm going to take you through the 3 various levels that are included in the manual in a very brief, concise way, so that you can also take a look and familiarize yourself and use these options that we have offered. Internal monitoring, which is basically quality improvement at facility level. This is usually led by health facility managers, and the manual covers the options used for internal monitoring. One option covered here is maternal discharge and follow-up surveys. As we may also know, maternal experience is really the most reliable source of information on the experiences that mothers receive in their postnatal care, and then surveying them as discharge or shortly after the services they've received is ideal for internal monitoring. And most of the surveys have been widely used to assess the care and quality, and can include the 10 steps. And the good news is we included an infant feeding patient exit survey in the manual, and some of the questions included there can be used as a standalone questionnaire or integrated in broader surveys. Then we also have the routine administrative data. As we may all know, many health facilities use HMI systems, for example, to collect data on planning for decision making. And some of these indicators are related to the 10 steps, like antenatal counseling, timing of first breastfeed, and infant feeding practices. Many of this may have already been captured. However, additional work may be needed to convert this into meaningful indicators. And then we also do know that HMIs also often have reporting functions built in into the BFHI to cover indicators. We also have the medical charts reviews, which are really also can be used for internal monitoring and can be used to track these indicators effectively, and can be used periodically and extracted from paper medical charts. Next, please. There is also an option for external monitoring, which, of course, you can review the internal monitoring reports and are useful if facilities do not conduct internal monitoring. And there is also an option for independent data collection where internal monitoring is not done at facility level. Then a critical part also is desk review of documents, which specifically relevant to steps 1 and 2, because the earlier monitoring options covered only look at steps 3 to 10. And then, of course, key informant survey, which really look at staff insights on policies and practices, as well as site visits on direct observation of the technical support and providing technical support as needed. But a combination of these methods can also be used as and when needed at country level. Next slide, please. And then we do have the national level monitoring, which is basically a collection of the other monitoring processes that have been described, but the difference is this is done at a larger scale. You do have the routine administrative data, which is usually extracted from HMIs or electronic data records. You have the maternal discharge and follow-up surveys, which can be used from those that have been conducted at facility level, and the population-based surveys, which can include questions around BFHI, as well as facility accreditation reports and supervision and key informant interviews. So with that, I will just go straight and introduce my colleague, Dr. Nina Chad, who is going to inform us about the second edition of the Infant and Young Child Feeding Model Chapter. Nina is a public health and nutrition specialist with over 20 years experience in shaping global policy and practice in infant feeding and child health. She currently leads the technical work on infant and young child feeding as a consultant with WHO. Dr. Nina Chad has contributed to global guidelines, authored technical guidance, and played a key leading role in development of the competency-based curricula for health professionals. She is known for translating complex evidence into practical tools and fostering cross-sectoral equity-focused collaboration. And Nina has worked with Save the Children in Myanmar and with the International Board of Lactation Consultant Examiners, developing training and policy frameworks. She is qualified breastfeeding counselor, master trainer, assessor, and curriculum designer. Over to you, Nina.
Thank you so much, Fatmata. Can we have the next slide, please? Many of the mothers whose voices we heard earlier today report that they have experienced gaps between the evidence around effective breastfeeding management and what happens in their interactions with clinicians. Many healthcare providers seem to lack confidence in breastfeeding support, and that's hardly surprising when so many of them report receiving minimal education or training on infant and young child feeding in their pre-service programs. To address this challenge, the model chapter was developed in 2009 to promote the integration of evidence-based clinical education on infant and young child feeding in the basic training of health professionals. In addition to providing a grounding for health professionals, the model chapter has become a reference where readers can find WHO recommendations summarised and applied in a single handy volume. Next slide, please. Because knowledge supports competence, it is essential that we provide knowledge so that healthcare professionals can provide quality care. Knowledge informs sound clinical judgment and initiates an orientation towards lifelong learning. Since the model chapter was first published in 2009, WHO has revised and updated several guidelines relevant to infant and young child feeding, which means that more healthcare professionals must develop competencies that enable them to support breastfeeding in a variety of contexts, including antenatal and postnatal care, in paediatric high dependency and intensive care units, as well as in routine well child care and nutritional treatment programs. Next slide, please. There are 8 sections in the second edition, which has been reorganised to reflect clinical practice, designed to support routine breastfeeding support, which it incorporates new public health priorities and is updated with the latest WHO recommendations. It contains key messages for each section, which highlight the important ideas that health professionals should take with them into their practices with mothers and infants. Next slide, please. Incorporating evidence-based clinical education on infant and young child feeding in basic training for healthcare professionals is an investment in the future. And the second edition includes recommendations, 8 sections, which include introduction, which includes the recommendations, the health outcomes of infant feeding practices, the epidemiology, and some information about the policy frameworks that we need to aim towards. It includes a section on anatomy and physiology, another on complementary feeding, another on perinatal care, community breastfeeding support beyond the perinatal admission, managing special breastfeeding situations, including emergencies, infectious diseases, malnutrition, relactation, and in the context of cancer treatment. It includes a section on common challenges and provides support for assessing and resolving issues such as mastitis and maternal illness. And also it also contains a new section on routine guidance that includes basic information about infant and young child feeding for healthcare professionals to share with mothers. Next slide, please. Incorporating this evidence-based clinical education is an investment, and it's an investment in the future. This World Breastfeeding Week, we are calling on medical educators to use the model chapter to integrate infant and young child feeding into pre-service curricula for healthcare professionals, to align policies, protocols, and practices with WHO recommendations, to inform evidence-based breastfeeding support and management, and to support professional development and in-service training. The model chapter will be available very soon. Please watch your email for the link, which we will send everyone registered for this webinar the very moment it's posted. Thank you very much for being here, and with such attendance, I am optimistic about our prospects of meeting the new 2030 nutrition target for 60% of infants under 6 months old exclusively breastfeeding. Thank you. And I'll hand it back to Fatmata.
Thank you so much, Nina, as well as Larry earlier on, for the excellent presentations. As we may have seen, these resources give us concrete ways to ensure healthcare competency, from verifying skills in practice to building foundational knowledge from the very beginning of the healthcare education. We look forward to sharing the links to these materials with you, and all registered attendees of today's event will receive an email with the links to the tools. Next, we will have a 4-person panel of experts from the Gambia, East Asia and the Pacific, the UK, and Lebanon, who will share their country and regional experiences in effectively strengthening the delivery of breastfeeding support in national and subnational healthcare systems. They will advise on how the new resources may be applied in their specific settings. I will take now the opportunity to introduce our speakers briefly here. We have Mr. Malang Fofana, who is the Executive Director of the National Nutrition Agency in the Gambia, with 30+ years of public health and nutrition experience. He is a pioneer of BFHI implementation in the Gambia. Then we also have Ms. Bincha, who is the Regional Program Officer for Alive and Thrive in East Asia and the Pacific, and is based in Vietnam. She leads and also provides technical oversight of evidence-based systems, including centers of excellence for breastfeeding in pilot sites. We also have Anne Woods, who is the Deputy Program Director for Baby Friendly program at the UK, UNICEF UK. She is a midwife with over 25 years in the UK Baby Friendly Hospital initiative. She leads assessment processes and sits on the International BFHI Network Board. And then we have Miss Pamela Zaghib, who heads the Mother, Child, and School Health Unit at Lebanon's Ministry of Public Health. She chairs the National Infant and Young Child Feeding Committee and leads multi-sectoral coordination efforts. So now let's hear their experiences in strengthening breastfeeding support worldwide. So I will start with East Asia with my colleague, Ms. Binter. And I know you have successfully embedded breastfeeding counseling into national quality of standards. Ms. Ter, please share with us how Vietnam is doing with these quality standards and what lessons have been learned in the process that other countries can learn from.
Thank you, Famata. Good morning, evening, and afternoon, everyone. So, thank you for your question. So in Vietnam before 2013, we didn't have a standardized system-wide way to assess and improve on national improve hospital quality. So recognizing this gap, the Ministry of Health developed the national hospital quality standard that was first launched in 2013 with the technical support from both local and international experts. So this standard includes 83 indicators across areas like patient care, staff training, and service delivery applied to all hospitals nationwide, both public and private, from district to central level. So the scoring system ranges from the level 1 to 5, with the level 3 being the minimum acceptable standards. So thinking about this opportunity to support the breastfeeding implementation, the stand staff was advocated to be integrated into these national hospital quality standards. This was very significant because BFHI has existed in Vietnam since 1994, but uptake was extremely low, with less than 1% of hospitals was certified, mainly because it was voluntary and came with extra workload and restriction. By embedding breastfeeding into mandatory quality assessment, breastfeeding counseling and support became a required standard in all hospitals providing maternal and newborn care. Regarding the lesson learned, I think a key lesson learned from Vietnam experience is that embedding breastfeeding standard into existing national system rather than relying on voluntary certification can drive real change. And using a standardized national qualities framework has also proven effective, not just for accountability, but for guiding and supporting hospitals to improve. Annual scoring, even with a focus on meeting the minimum grade, has a motivates better breastfeeding counseling and early initiation practice. So overall, aligning breastfeeding support with national quality and monitoring system while keeping expectation realistic but mandatory can lead to sustainable progress. Yeah.
Thank you so much, Ms. Ter, for that brilliant experience sharing there. I will go to Ms. Woods of the United Kingdom. I know the UK has a strong bottle feeding culture. How how have the UK been able to pivot and embed breastfeeding support into their national healthcare systems, and what strategies have worked best?
Hello, everyone. Thank you, Fatmata. I think in the UK, we've got a very long-standing baby-friendly hospital initiative history. We've been running for over 30 years. I think there's been over that time a recognition that it is an evidence-based programme and that it works and it's very well respected. We haven't just relied on sort of word of mouth, we have worked tirelessly to engage the governments of our 4 nations to the extent that now baby-friendly breastfeeding, 10 steps is all very strongly integrated into a lot of policy. It's much more strongly integrated in our 2 devolved nations, Scotland and Northern Ireland, where they have infant feeding strategies which require all services, hospitals, community services to become baby-friendly accredited or designated. And we're now at the point where 100% of services in those 2 countries are in that position. England and Wales, there is a lot of strength in policy documents suggesting that this happens, but it's not got the same requirement behind it. We've seen really positive outcomes from that. So, for example, we've had a long-standing infant feeding survey. It ceased in 2010. We've had another one in the last year or so. We're waiting for the outcomes of that. But Scotland did their own survey back in 2017. And as I say, all services there are accredited, and they managed to show 5% increase in any breastfeeding at 6 weeks and an 11% increase at 6 months. And it was particularly notable that families from populations that haven't traditionally breastfed were more likely to be breastfeeding. So I think that shows the impact of the programme in the UK. I think one of the key things we did was to have a look at the 10 steps. Back in 2012, we had a look at our own programme. We looked at it with a child rights perspective, we looked at the evidence, and we also considered the sort of growing body of evidence at that time around the impact of neurodevelopment, of responsiveness, of nurturing, and added a standard into our own standards around that. And I think that helped to really reinvigorate interest at that time. On a more practical level, one of the things that we require is that each service has a dedicated infant feeding lead or team, so that there's somebody tasked with implementing breastfeeding baby-friendly standards within that service. And we coordinate a network of all of those. There's over 800 leads across the UK who have a really powerful voice now in terms of lobbying services, local government, and we've also got a strong history and of working with our voluntary agencies, our mother support groups, who work very much alongside hospitals and community services to support baby-friendly and breastfeeding for mothers and babies. We were the first country to introduce community standards, again, recognising the specific sort of situation within the UK.
Thank you so much, Ms. Woods, for highlighting the impact of the program in the UK. Really appreciate you sharing this experience. And now, Ms. Zohaib, I know Lebanon is a country experiencing development and humanitarian crisis situation at the same time. Could you please describe how Lebanon is embedding breastfeeding support into the national healthcare systems from both perspectives? Are you there, Zaid?
Oh, sorry, I forgot to unmute myself. So sorry about that. Hello, everyone. So I was telling you that in Lebanon, embedding breastfeeding support into the national healthcare system, has been approached through both system-level coordination and service delivery integration. At the system level, we had institutionalized the breastfeeding protection and promotion through the Infant and Young Child Feeding National Committee, which is shared by the Ministry of Public Health under the Mother and Child Health Department, and it includes a representative from all sectors, UN agencies, NGOs, international and local NGOs, syndicates, orders, and academic institutions. So this committee oversees the implementation of the National IYCF Action Plan. It promotes compliance with the International Code of Marketing of Breast Milk Substitutes and Lebanese Law 47/2008. Okay, so, and it provides strategic and technical guidance for integrating IYCF into national health programs, policies, and emergency preparedness plans, because Lebanon encountered a lot of emergencies lately. One of the most impactful initiatives is also the Baby-Friendly Hospital Initiative. As part of our efforts, we have 15 hospitals currently enrolled in this national program, and and including one public hospital. So we have 3 already hospitals that achieved the Baby-Friendly Hospital designation. And they are supported to implement the 10 steps through successful breastfeeding. They receive training to their staff, provide quality counseling to mother immediately postpartum, and we integrated the 10 steps of the baby-friendly hospitals and the accreditation of the hospitals in Lebanon. And this was very efficient because we can sustain it and encourage other hospitals also to be enrolled in this program. From the service delivery perspective, we have several interventions that are being scaled, notably the National IYCF hotline, which has proven to be one of the most impactful. Why? Because the hotline offers free, skilled counseling to pregnant and lactating women, as well as the mothers with questions about complementary feeding. It is accessible to all nationalities living across Lebanon, because we have a lot of refugees, including during emergencies, such as the most recent conflict, ensuring continuous support even in time of crisis. The hotline also functions as a platform to report the code violations, and ensures follow-up through a network of trained IYCF community counselor. So between January and June 2025, the hotline received 914 calls, which 251 referrals made for personalized IYCF support, many of which originated from BFHI enrolled hospitals, and it demonstrated strengthened continuity between the facilities. Just for you to know that Lebanon is a small country, so we are not, so when I say 914 calls, it's a lot, because we are like 5 to 6 million people. So that's
Thank
it
you
for this question.
Thank you, Ms. Zaheb, for showcasing what is possible within the context of humanitarian and development settings and embedding breastfeeding support into the national health systems. Thank you. So I'm gonna come to Mr. Fofana from the Gambia. You have been implementing BFHI within health facilities since 1992, and since then, you have successfully increased your exclusive breastfeeding rate. We all know the value of embedding breastfeeding support into the national healthcare systems. Can you please share how Gambia has addressed the challenges at community level, and how you have linked the hospital to the community and engaging influencers to increase this breastfeeding rate? Over to you, Mr. Fofana.
Thank you very much, Famara. Very good morning from the smiling coast of Africa, the Gambia. The Gambia has piloted the global initiative in 1992 to test how the initiative will work in our local context. In the implementation, we realized there are a few challenges that we face, one of which is the implementation of the 10 steps to social breastfeeding as outlined in the BFHI. But also we realized that majority of births occur at the community level. At the time, over 70% of births occur at home. And even if mothers deliver at the hospital, they don't stay there long. They only stay there for a few hours and they go back into the communities where traditional and cultural practices prevail. But along the line, we also realized that while we are implementing the BFHI, the focus of the health education, the counseling is only on the mother. And we know that the mother has some people around her at home. If they are not supportive, she may not be able to practice what we are advising them at the federal level. So what we did in the Gambia is to expand the hospital initiative into a community initiative, where we ask more communities to identify what we call the village support groups. These are a group of 5 women and 3 men, including the traditional birth attendants and also the village health worker, who are trained and certified as counselors, but also as change agents in the community. And they go into the community to carry out home visits, group and individual sessions, drama, role plays, and entertainment education to inform, educate, and communicate on infant and child feeding, particularly more so on breastfeeding. But we also expand the health education from information education communication to behavior change communication, because we know that to influence behavior, you must go beyond education alone, but we have to ensure that the needed requirements are met at the community, particularly expanding the education to include the society. That together can help us to. So we expand on the social and behavior communication to inform, educate, and to encourage people to adopt the desired behavior that we are promoting. In the community, the IPC networks are very influential in delivering and supporting mothers to adopt the behavior. But we also have what we call the community health nurses. These are trained health workers who are posted in the communities, and they are living in the community, very close to the community. They serve 2 purposes. One of their purposes is to empower the village support groups or the interpersonal communication networks in the communities for them to be able to perform their work, but also serve as a referral point for health facilities where a mother is discharged. They are referred to this community health nurse. He then or she will then, is mobile, will then follow up and provide the necessary advice to the mother in the community. So we have a host of strategies that we are doing to ensure that the mother get the support from the facility to the community.
Wonderful. Thank you, Mr. Fofana. There's a really excellent insights on the importance of expanding and linking community support in healthcare systems, and also highlighting the importance of behavior change and the use of community health nurses. So in the interest of time and to ensure that we hear from all of our participants, let me turn back to Ms. Thier from Vietnam. Ms. Thier, I know since 2018, WHO and UNICEF guidelines have changed from accreditation of BFHI to fully institutionalize it within the standards of care. Can you please share what you're doing in East Asia and the Pacific region to motivate and recognize hospitals that have successfully instituted the 10 steps to successful breastfeeding? Ms. Thier, over to you.
Thank you, Famata. Thank you for your question. Yes, in 2018, Alliance Right collaborated with government and local partners to revise the national BFHI implementation guideline and implement a novel model that we name it Center Excellence for Breastfeeding, integrating BFHI into national system of Cambodia, Laos, and Vietnam. The COE initiative does not replace the existing BFHI system within Vietnam, but rather builds up the existing BFHI structure, providing both current BFHI and non-BFHI hospitals with the chance to enroll in the initiative and incorporate a performance-based model to guide implementation of BFHI services. To motivate hospital, we focus on three things. The first one, we provide technical assistance to improve breastfeeding support practice. We train mothers, trainers in hospitals and use simulation-based coaching to strengthen early essential newborn care and breastfeeding counseling. Second, we offer public recognition and wide dissemination of CW status. Following CW designation, hospitals receive a recognizable signboard with a logo for public display. Their accreditation is published in the media and on breastfeeding community social media platforms. And lastly, we prioritized timely feedback from mothers and family to facilitate hospital performance improvement. A notable component of the CUE is the birthing experience monitoring tool, which routinely collect mother feedback on the quality of breastfeeding support and ENC they receive at the hospitals. Digitalizing the tool allows health manager and practitioner to receive real-time feedback from mothers about adherence to the International Code of Marketing of breast milk substitute and quality of care during the antenatal, childbirth, and postpartum periods from facility to national level. Since 2019, over 14,000 mothers have shared their experience using the tool, and 94 hospitals in these countries enrolled in the initiative with 44 designated SUV and benefiting over 250,000 mothers in the sub-Mekong region. So this approach has created healthy competition, improved quality, and ensure more consistent implementation across hospitals.
Thank you.
That's
Thank
my
you
sharing over to
so
you,
much.
Mamata. Yeah.
Thank you so much, Ms. Chair, for that enlightening overview there on how you've incorporated performance-based model on BFHI implementation and the provision of technical assistance, as well as using public recognition and then prioritizing timely feedback from mothers, and for sharing with us your impressive numbers in terms of reach. Great. So I am going to hand over to Ms. Ann Woods now to throw light on what challenges they still experience in strengthening support within the healthcare systems and how they're working to overcome them.
Okay, thank you. Yes, there are still a lot of challenges, still mountains to climb, I think, to get standards fully implemented across all hospitals and other services across the UK. Certainly, I've already mentioned about the differences within the devolved nations and the difference in policy directives that support the programme. I think, as in, I'm sure globally, we have incredible workforce pressures, staff shortages, and I think, and again, probably a global issue is the increased acuity that mothers are having. You know, mothers are older, worse health outcomes, greater incidence of caesarean sections, all of which leads to additional support being needed to enable them to establish and maintain breastfeeding. I think another challenge, which again will resonate and has been talked about, is the challenge in training. We do have university programmes here in the UK, and they've proven to be successful with midwifery and public health nursing programmes, so that those professionals enter the workforce already able to sort of hit the ground running and provide effective support. We've now got 42% of our midwifery programmes accredited or designated, and 23% of our public health nursing programmes. There are health visitors who support mothers and babies from birth to 5. We don't have similar programmes for our general nursing courses, and those nurses end up working in our neonatal units and we don't have similar programs for medical staff. So that is a challenge which needs to be addressed. And I guess, again, with everybody, commercial influence, we don't fully implement the International Code of Marketing of Breast Milk Substitutes in the UK. We have our own UK law, which is not as strong. We do have the code as a very strong standard required as part of baby-friendly assessment, and that is implemented across those services. But the big challenge that I guess everybody is facing is around the digital marketing and how to counter that.
Great. Thank you so much, Anne, for really sharing those challenges and how you're working towards overcoming them, and also sharing those impressive numbers. I will come now to Ms. Ayub to ask question about how you envision to use the tools presented here today and applying them in your setting. You can just select one tool. You don't have to do all, but of course, it's up to you to decide on what you want to talk about here. Ms. Zib, are you there? Have we lost Ms. Zib? Well, while waiting for Ms. Zib to come on, I'm just gonna switch over to Mr. Fofana. I know another area that the Gambia has successfully improved and the enabling environment is through maternity leave. Can you please describe how what you can advise other countries looking at improving this?
Thank you, Farmata. Maternity leave was a challenge at the beginning because when we started the idea of promoting exclusive breastfeeding for 6 months, we realized that working mothers have a challenge, especially when the 6 weeks is over. So what we initially do is to look at it in terms of policy and legal framework. We mainstream infant and child feeding into national policies, including the national policy, the gender and women empowerment policy, reproductive child health policy, and several other policies, to provide us the basis for promoting exclusive breastfeeding in the country. However, to legalize this, we mount a strong educational advocacy campaign when the Women's Bill was being prepared, to ensure that the 6 weeks is increased to 6 months maternity leave. And thankfully, in 2010, when the act was enacted, it included a part 5, subsection 2020, that gave every working mother 6 month maternity leave with pay or with comprehensive benefits without loss of employment or seniority or any similar benefit to the mother, but also give fathers a 10 days maternity leave for every child delivered to the father. So this is done because we have done a comprehensive advocacy targeting the National Nutrition Council, the National Assembly, the Women's Council, the Consumer Protection Associations in the country, all of which were informed, educated, and communicated and advocated for this to happen. So my advice to other countries is that if they are to achieve this, first you have to ensure that you mainstream nutrition, particularly infant and child feeding, into national policy frameworks, and also to mount a strong advocacy campaign targeting key stakeholders, particularly those that are responsible for policy and decision making.
Wonderful, wonderful. Thank you so much, Mr. Fofana, for those insights. I can see we have Lebanon back. Are you able to speak now, Ms. Zeb?
Yeah, sorry for the inconvenience. I lost the connection. I had an unstable connection.
No worries. So how do you envision that the new tools presented here today will be applied in your context?
So in Lebanon, one of the tools I see as particularly relevant is the forthcoming competency verification toolkit, which focuses on building and verifying the lactation support competencies of healthcare workers at both facility and community levels. In fact, this aligns closely with the community-based infant and young child feeding counseling package currently being drafted by UNICEF Lebanon. So we are working on this right now in collaboration, of course, with the Ministry of Public Health and the IYCF committee. This package is designed to strengthen community-level IYCF support by providing standardized counseling materials and building the capacities of frontline workers such as IYCF counselors. So once finalized and rolled out, this CIYCF package will offer a localized practical framework for delivering consistent evidence-based counseling across Lebanon, and it will also lay the foundation for competency assessment and verification, make it an ideal complement of the competency toolkit. So together, these two tools will contribute to scaling high quality breastfeeding support, and it will ensure that caregivers receive accurate guidance with their communities.
Wonderful. Thank you so much, Ms. Zib, for really showcasing how these tools will be used. That's really what we want to see that countries are using and applying these tools. So at this stage, I want to thank all the panelists for such an engaging and informative discussion about what's happening in their regions and countries. We really appreciated learning from your experiences. So now we are going to take time and answer some questions from the panelists. And I will ask all speakers and presenters to just be on video so that we can take the questions. Wonderful, wonderful. Thank you all. So I have a question here. Perhaps I can pose it to Thea, which is really about the extent of digital monitoring. The question is, to what extent has the role of digital and data systems has been considered in supporting improved clinical practices for breastfeeding? I would like to pose this to Tia, if that's okay with you. And every other member of the panel can also chime in and respond to this. Can you hear me, Tia? Or did I? Hello?
Oh, you're calling me, right, Famata?
Yes, I'm very sorry about that.
I'm
Yes,
sorry about that.
I was just asking a question here that is posed from the audience. The question is, to what extent has the role of digital and data systems been considered in supporting improved clinical practices for breastfeeding? I know you've worked a lot on digital systems in Asia around us. Are you able to provide insights to this question?
Yes, thank you, Famata. So regarding the digital and data system, so for example, in our region that we are focusing in Cambodia, Vietnam, and Laos. So in our CW implementation model, we have the independent tool to support the to collect the independent information from mothers that we call, as I introduced before, that the birthing experience monitoring tool. So this tool will be, the process is that the independent enumerator will select randomly select the mother after discharge from hospital in the network, and they will call and ask the question and collect all the information and provide input into the digital system, the BEMT tool. So the tool will support with the analyzing, create the report automatically, and all the hospital in the network can review the report in the real time. So it's a kind of digital and data system that we are working on and support in the region. So I think we have received many feedback from the hospital, the health facility in this country about the role and the importance of this system to support their hospital improvement plans. Yeah, over to you, Famata.
Thank you so much, Tia. I think you really made very beautiful insights there in terms of the experience in data. I don't know if any member of the panel will also have additional insights to throw in here. But perhaps I can ask this question to Anne here. What changes have you made to patient records to support implementation and monitoring? I know you worked a lot on BFHI in your context. Are there any experiences you can share to respond to this?
Gosh, yes, I'm sure I can. We have traditionally had paper records that mothers carry, their own handheld records throughout their pregnancy. And we have a patient-held child record, which transfers from pregnancy right through to the care through the health visiting service. And we have influenced quite a lot of the content of that to make sure that it fulfills the requirements of the 10 steps, the baby-friendly standards. One particular tool that we introduced a little while ago was a sort of almost like what we call a breastfeeding assessment tool, and we also have a bottle feeding version when mothers are not breastfeeding. But that's a specific sort of set of questions, if you like, that guides the health professional to ensure that breastfeeding is effective. It's used with the mother, you know, it's a visual tool for her as well to be able to see and build her confidence to know that her baby is feeding effectively, that there's sufficient milk transfer, that the baby is, you know, the output is what you would expect. So that is a tool that has gone into all of services' handheld records. A lot of services are now moving on to electronic patient records, and those, you know, that experience they've had with what's useful in handheld records is transferring into that, not without hiccups, I wouldn't say, in a lot of services, because, you know, you change a system and it takes a little while for staff to become confident with how to input into all of the fields, but that's a sort of a learning piece of work at the moment. One particular thing that it's helpful for, I think, in hospital settings is to be able to monitor supplementation rates, because it can give services an ongoing measurement percentage of their supplementation rates through the electronic patient record.
Great. Thank you so much, Anne, for the insights there and for sharing the experience from the UK. So I'll just like to round up on the Q&A and throw these questions, these two questions, to one Larry and then the other to Nina. One is, how have health systems ensured health professionals maintain their knowledge and skills over time? And then how do we ensure new recruited midwives, nurses, and doctors are equipped with the knowledge and skills they need to support breastfeeding effectively? Not in any particular order. Anyone can just chime in and weigh in on the questions.
So I guess one of the things I can share around ensuring newly recruited midwives, nurses and doctors are equipped with knowledge, skills and attitudes that they need to support breastfeeding effectively. It's one of those questions that is really, it depends on the kind of educational and credentialing systems that you have in your country and within your healthcare system. So I think if there is a kind of strong health professional credentialing system that that prescribes the competencies that healthcare professionals need to have to perform their roles, then including breastfeeding support and management competencies within those kind of requirements for registration, say, as a midwife or a paediatrician or a general practitioner will be really important. Colleges and, you know, colleges of paediatricians and nurses and midwives can also I guess, include requirements for continuing professional education and for competency verification of those over time. And that will, I mean, many countries require all registered healthcare professionals to complete a certain number of hours of continuing professional education every so many years. For many, in many countries, things like basic resuscitation must be refreshed and demonstrated every 12 months. And so there's no reason why we can't think about doing something similar for our breastfeeding competencies, which are perhaps just as important.
Thank you so much, Nina, for weighing in there. I know Larry also wants to weigh in. Larry, over to you.
Weigh in really quickly because I know we're running short on time here. I would just mention that I think that countries are really struggling with this. There's a real competition in space in medical schools for training, and oftentimes breastfeeding gets set aside as not the top priority, and we leave it to kind of on-site training, and it is very much focused on just to sit in a course, and we don't do a lot of verification. I think it's really time for a paradigm shift in thinking about the importance of really ensuring that staff have the competence that they need. That means we need to do more in pre-service education. It means we need to be really checking on practical skills. We need to make sure we're really focusing on the knowledge that's most important. It really is time for countries to think about breastfeeding education in a very different way, to really focus in on the skills rather than just we've sat in another class. Even those classes, typically with train the trainer, cascading down, we find they don't get the training that they really need through those processes. And so it's time for us to rethink it.
Beautiful. Thank you so much, Larry. And thank you all today, the panelists and everyone, for this conversation and for providing really great insights to the topic. So before we leave you all today, we first of all want to thank all the members of the Global Breastfeeding Collective webinar task force that has really put in the work into having this webinar today. Thank you all very much. And as we wrap up today's webinar, I really want to leave you all with 3 key actions that we all can take to truly transform the healthcare systems for breastfeeding mothers and babies. First, we need to strengthen the healthcare system accountability. What do we have to do? We must build robust internal monitoring systems that hold healthcare facilities accountable for providing appropriate breastfeeding support and counseling to mothers throughout their entire journey. This is from pregnancy to 2 years and beyond. And the monitoring manual we have had about today gives us exactly the framework we need to make this happen. And then secondly, we need to ensure that healthcare staff have the competency. This basically means investing in building the capacity of health staff by ensuring that they have the adequate competencies to provide skilled breastfeeding counseling that mothers need. And the competency verification toolkit and model chapter we explored today provide us with the competency-based assessment and tools to make this reality a reality for mothers. And third, We have to allocate dedicated funding. This is so important given the context we all work in now. We must secure sustainable funding to implement and maintain this healthcare system improvements, including staff, training, monitoring systems, and ongoing competency development. Because without proper investment, even the best tools and intentions will fall short. So with that, I thank you all for joining us today, and best wishes for a great rest of the day and evening. And have a beautiful day. Bye-bye.
Thank you. Thank you.
Thank you, everyone.
Thank you, everyone. Thank you.
And
Thank you, everyone.